Hello, my name is Dr. Sumera Ahmed. I'm from Touro University, California. Also on the board member of American College of Diabetology. Today's topic is on monogenic diabetes. So let's look into the clinical characteristics of MODY or the monogenic diabetes. So the family history, we did see that it's an autosomal dominant inheritance. So the family history is really important. So at least a three generation of more family history should be obtained. And we should pay particular attention, not just to the history of diabetes, but also more pertinent details. Like we want to ask, what was the age of onset of diabetes in the family members? What was their body habitus or BMI at the time of diagnosis? Did they require insulin? What medications were used for them? And was any molecular genetic testing was done in these patients? And again, another characteristics of MODY is the early onset diabetes, as we saw it occurs typically or classically before the age of 25, although it could occur by age 30 or 35. And then this type of MODY also has features which are atypical for type 1 diabetes. So they do not have any presence of autoantibody. The pancreatic islet cell antibodies are negative. They require very low insulin. And also, if you were to check the C-peptide, even 3 to 5 years after diagnosis, they do have a detectable C-peptide, typically greater than 0.6 nanogram per ml, with a corresponding glucose of greater than 72 milligram per deciliter. And in the features, another feature for this type of MODY is if insulin was omitted or if they missed insulin, they would not go into ketoacidosis, unlike our patients with type 1 diabetes who would go into diabetic ketoacidosis if they miss insulin even for 24-hour period. And other features that are atypical for type 2 diabetes that we see in MODY or monogenic diabetes is the onset of diabetes. So typically in type 2 diabetes, the age of onset is greater than 45, whereas here its age of onset is less than that. They do not have any signs of insulin resistance like acanthosis nigricans, so they have absence of acanthosis nigricans. And also the lipid profile. Like we do know in people with type 2 diabetes, they have the diabetic dyslipidemia, so they have high triglycerides and low HDL, whereas in people with MODY or monogenic diabetes, they have a normal triglyceride level, and they may have a normal or elevated HDL. And these typically present with mild, stable fasting hyperglycemia. They are very sensitive to sulfonylureas, and depending on the subtypes, they may also have those extrapancreatic features. So when do we consider MODY? So if someone has a diagnosis of type 1 diabetes, but they have negative islet cell antibodies and antibodies, and they have a preserved beta cell function, and the insulin requirement is very low, then consider MODY as a possibility. But if someone's diagnosed with type 2 diabetes, but they also lack the signs of insulin resistance, then you want to consider if it's a MODY or monogenic diabetes. So how do we diagnose? So there is the MODY risk calculator, which is a helpful tool that can help us in guiding a further testing for MODY. So this is available at the diabetesgenes.org. And this is a calculator that has been developed by the University of Exeter group, and it's been validated in Caucasians between the age of 1 to 35 years of age. And they usually account for the three most common types of MODY, the GCK, HNF1 alpha, and HNF4 alpha MODY. And this calculator uses the current age of diagnosis, the sex, the ethnicity, the treatment regimen, the BMI, the A1C, and also the parental history of diabetes, and would also ask for any other chronic medical conditions associated with MODY phenotypes, and it calculates a post-test probability of MODY. So if the post-test probability is more than 10% for someone who's on insulin, or if the post-test probability is more than 25% for someone who's not on insulin, then you want to consider genetic testing for these patients. But again, there are some limitations with this calculator because it was mainly validated in Caucasians. Its applicability to other races and ethnicities is yet to be determined. And although it has been shown to perform well in Asians based on a small study, which included participants of mixed ethnic groups, namely Chinese, Malay, and Indians, and it seemed to have some efficacy in Asians with this calculator. But again, we also want to keep in mind that it may not be applicable as it's considering only the most common subtypes of MODY. So genetic testing, there is possibility of doing genomic sequencing or exome sequencing testing in the research setting. The RADIANT group, which is the Rare and Atypical Diabetes Network, this is a US-based NIH-supported national consortium, which is studying atypical forms of diabetes. And if someone who has not been previously identified with a genetic etiology or has not had any molecular testing done, then the RADIANT is a possible place that you can reach out to because as they're a good source. And also the Monogenic Diabetes at University of Chicago is also a good resource as they have a MODY registry, which has been established since 2008. So these are the other genetic labs which are available in the commercial setting. So this is the Athena Diagnostics. Then we have the University of Chicago has the Clinical Genetics Lab and also has the Monogenic Diabetes Registry. And then there is the Baylor Genetics and the Invitae. And some of these labs may also provide financial assistance for qualified applicants. Let's look into the diagnostic algorithm. So if you have someone based on the history, physical examination, and a 3+ generation family history, and have clinical characteristics that are suggestive of MODY or monogenic diabetes, then the next step is do the autoantibody testing. So you want to screen for at least 3 antibodies, the GAD65 autoantibody, the IA2A, and the zinc T8 transporter autoantibodies. And if these antibodies are negative or if they're very low titer, then you can consider doing a molecular genetic testing. And there are other supportive testing that can also be considered, doing a fasting C-peptide level with a corresponding glucose level, especially 3 to 5 years after their diagnosis. And if they have a detectable C-peptide greater than 0.6 with a corresponding glucose of greater than 72, then you can consider genetic testing. And also checking for a high sensitive C-reactive protein, which is typically noted to be higher in the HNF4 alpha MODY. And then there's another testing called the urine C-peptide and creatinine ratio. So doing a 2-hour postprandial urine C-peptide to creatinine ratio, if that is greater than or equal to 0.2, that helps distinguish the HNF1 alpha and the HNF4 alpha MODY from type 1 diabetes. And then we had the clinical risk calculator as well. So comparing the atypical forms, so we have to distinguish between MODY type 1 and type 2 diabetes. So we saw the typical age of diagnosis for MODY is typically less than 25, and even for type 1 diabetes is in a younger age group, whereas type 2 diabetes is commonly seen in adulthood, although we do see now in the pediatric age group as well because of increase in obesity. Then the parental history is very high, strong in MODY with 60 to 90% parental history, whereas type 2 diabetes is 10 to 14%, and type 1 diabetes is less than 10%. And the inheritance pattern we saw is autosomal dominant for MODY and polygenic for type 2 diabetes. And the presence of obesity and insulin resistance and metabolic syndrome is commonly seen in type 2 diabetes, whereas it's uncommon in MODY and type 1 diabetes. The presence of beta cell autoantibodies, these are absent in MODY and type 2 diabetes, whereas they are present in type 1 diabetes. And the beta cell function reflected by the C-peptide levels. The C-peptide levels are normal in MODY, whereas they're undetectable in type 1 diabetes. And in type 2 diabetes, earlier on in the disease, they may be high. With progressive disease, they may have some beta cell dysfunction. So to summarize, the MODY or the monogenic diabetes is an autosomal dominant, milder form of diabetes. And you want to suspect if you see diabetes that is present in every generation, and you want to remember that MODY can masquerade as type 1 diabetes. So if you have a patient with type 1 diabetes but has atypical features, then consider MODY. Again, this is a diagnosis. If you have you want to have a high index of suspicion. So because these patients can present early in the life, but can also be missed until the adulthood. Genetic testing is possible. both in the research setting and clinical setting. In the clinical setting, you want to use only CLIA certified labs should be used. And there is a list of labs on this website. And there is also a national registry of MODY at the University of Chicago. And based on the genetic testing, if you can categorize them if they are the GCK MODY, the HNF1 alpha, the HNF4 alpha MODY, or the HNF1 beta MODY. And this is important because if it's GCK MODY, they do not require any treatment. Whereas if it's HNF1 alpha or HNF4 alpha MODY, they would respond really well to low dose sulfonylureas. Whereas HNF1 alpha MODY, as we saw, would require insulin. So with that, this is the end of the presentation. Thank you.